Ma'am, we are ready to go.
Okay, great. Thank you. Good evening, everyone, and we welcome you to this No Thrombosis National Workshop once again. And I'm sure today also we brought some exciting cases for you all to discuss and learn from something from those cases. So quickly, please let me introduce our faculty for today. So definitely our course director today for the meeting is Dr. S. Minakshi Sundaram. He's a senior consultant neurologist, Apollo Specialty Hospital, Madurai. He has more than 20 years of experience in neurology. He has participated in research work and various workshops under the neurology department and published many papers. And he has affiliated with various societies and academics like Neurological Society of India, Indian Academy of Neurosciences, and American Academy of Neurology. Welcome, sir, for today's workshop.
Namaste, madam. Namaste. Thank you very much.
The first moderator for today's session is Dr. Balamurgan Namasivayam. He is a senior consultant neurology SIMS Chelem Hospital, Salem. He has many honors and awards to his name, and to name a few, he has received or he has orated in Ibrahim Bhailin on epilepsy in tropics. His best paper award at Association of Physicians of India, and he has also got several awards like Psychon and Tapicon. He has also received Doctor's Day Award and Best Faculty Award in Indian College of Emergency Medicine. He has also given a presidential oration in API Tamil Nadu Chapter Conference, and he has been a chairman of Association of Physicians of India Tamil Nadu Branch 2024-25. He is contributing to author in several textbooks like textbooks of emergency medicine, neurological examination, and many others. He has more than 25 publication in PubMed Index Journal, more than 100 guest lecture delivered, and he has been course director for fellowship in neuroemergency by the Indian College of Emergency Medicine. Welcome, sir, for today's meeting.
Hello, welcome. Hello. Am I audible?
Yes, sir.
Yeah. Okay. Great. Good evening to you all. Yes. Please proceed.
Okay. We have our second moderator, and we're expecting her to join. So she's Dr. M. Kavita. She's a senior consultant neurology and HOD, Vellamal Medical College Hospital, Madurai. She has a teaching experience working as an assistant professor in pediatric of Department of Pediatrics, Kasturba Medical College. She has also presented and published many papers and has been expert in electrophysiology and transcranial doctor. She has won first prize in paper entitled "Study of Immunogenicity, Safety, Efficacy of HIV Vaccination" in Pedicon 32nd Annual Conference of Indian Academy of Pediatrics, and also won award for paper entitled Study of Catamenial Epilepsy in International Conference on Neurology in Malaysia. We have our first speaker, Dr. N. Vedan Yagam. He's a senior consultant neurologist, Sri Ramakrishna Mission Hospital, Coimbatore. He has completed MBBS from Perundarai Medical College and Research Center, DNB Neurology from NBE 2017, and DNB General Medicine from National Board of Examination. The special interest of Dr. Vedan Gamma are stroke, thrombolysis, Parkinson's disease, epilepsy surgery, and neurocritical care. And he has also participated in various research work and workshop under the neurology department and published many papers. The second speaker for today's is Dr. Jay Shankar. He has over 150 diagnostic neuro interventions and 50 therapeutic procedure. He has also done fellowship and training as advanced training in endovascular neurosurgery, Kazakhstan, XMIN 5.2 in Prague, Transradial in Neurointervention Mini Fellowship Life Hospital AP, EDSI, European Diploma in Ischemic Stroke Intervention. He has published studies on myelopathies and cerebral venous sinus thrombosis. And he was awarded third prize in poster presentation in Neuro Update Chennai and second prize in quiz competition Golden Jubilee Meet Madurai Medical College, and he has been senior consultant neurologist in Amala Institute of Medical Science, Thrissur. So we are expecting him as well. And that's it from the introduction round, and I will give it back to sir to please take it ahead.
Thank you, Dr. Pratiksha, for a nice introduction and putting us on the stage. Welcome to this very interesting program on no thrombosis. Welcome. It's a very unique program where students learn, and we also faculty we learn a lot from interacting with our colleagues. And Professor Dr. Subhash Paul sir, our teacher, used to tell us that the neurology, your techniques of treatment comes from RCTs, and individual case teaches you a lot. And that's why Dr. Adams writes neurology learned stroke by stroke. And this unique program gives us good insight into various management aspects of stroke, especially during the acute management. And I'm very happy to be sharing the stage with one of my gurus, my teacher, Dr. Bal Murugan, who is there with us. He is a guiding force for all of us in neurology. We all know his teachings. And then Dr. Kavita Madam, so who is my colleague in Madurai, and two wonderful speakers we have today from where we are going to learn a lot. So with this, I hand over the stage for the first few words with Dr. Mal Murugan, and then the speakers can go on stage. Thank you very much once again.
Thank you, Dr. SMS. Thank you for the introduction. I think that we are on time, 8:37. We will ask the first speaker to start with the case presentation. Dr. Veda is
Yes,
there
sir.
on. Yes, Veda, you can share and then we can start presenting the case.
Yes, sir. Sure, sir.
Yes.
Sir, it is opening, sir.
Yeah,
Is it?
We are able to see the
Welcome.
thing that
Oh,
Welcome,
okay.
madam.
Yes, sir.
no thrombosis.
Oh, yes. Is the slides are visible, sir, now?
Not yet, not yet.
Now, sir?
It will take some time, that not yet. Not
Okay.
yet. You can click the slide and then you can.
can you double click, sir? Maybe it's not opened.
You did it.
Are you able to see the slides, Dr. Veda? In your
Yes, sir. Yes, sir. I am able to see.
Sir, you have to stop sharing your screen.
Yes, I will do it.
Yeah. Once it is stopped, then let me know. Okay. Now you have to share your screen and one pop-up will visible. On that, you have to select entire screen.
Yes. It is coming like this.
Yes, you have to
Ah.
select entire screen. Then you can click on that share button. Uh, we are able to see your desktop file manager.
Oh, it is not there. So I will do one thing. I will close
You
that
are
everything.
able to see your PPT?
Now I am able to see, but you are now can you able to see?
Or what else you can do is you have to share your first you have to open your slides, then you have to share your screen, and when the pop-up comes, you have to select your PPT there. So what will you have to do? Just open your
Yes.
presentation in slideshow mode first, then share your screen.
Yes, I did it again.
Okay.
earlier it was coming, no? Earlier it was coming with
Yes, sir.
the slide. So, or you can go back, you can always, it always
Sir,
happens.
otherwise we can do one thing. I think I have sent my PPT to the person. The mail I have received, that person has.
No hurry, Dr. Veda, you can start that. They can do that also. You can come out and then you can read it.
Yes.
You can come out and then you can do it. Again, you can do it.
Yes.
I have also shared my email ID in the chat box. If you could just mail it to me and share it from my end.
I have received, sir. I am just trying to share. Just a second.
Yeah, you're right.
Krishna, you can share. Yeah, sir. I am sharing. Sir, I hope it is visible.
Yeah,
yes. Sure.
Just make it full screen. Now, sir.
Yeah. Yes, it is visible. Two different cases of seizures and stroke by Veda. Like, yes, sure.
Yes. Who is operating? Krishna? So who is operating my slides, please?
Krishna, sir.
Krishna. Hello, Krishna. Hi. So when I'm saying yes, no, the or next, you can move it
I'll
up.
do so. Yes, sir. I'll do
So, so good evening, everyone. As a good evening, Dr. Yuma sir, Dr. Bala sir. I am always your student. Now I am also a student. I am going to present two different cases of seizure in a stroke. So the two cases, the one case presented with the seizure as because we not thrombolized. The second case presented with seizure because of thrombolysis. So let us see go. Let us going to see the two cases one by one. So I start with my first case. The next slide. Slide 1. Next slide. Krishna, you can move.
Yeah.
Case 1. She is a 48 days female presented with acne, and the stroke window is 10 hours duration. So on examination, she is conscious, oriented, has a dysarthria, human facial weakness, ataxic right upper and lower limb weakness. She has a NHS of 7/42. So she is not ideal case for thrombolysis, but we can do with a thrombectomy or thrombectomy or thromboplasty we can do. So next slide. Next slide. Krishna, next slide. So this is the MRI picture of the patient. You can see the gangliocapsular infarct, which is a diffusion weighted image which shows acute infarct. Next slide. The MRI showed there is a complete occlusion of the both carotids. You can see the base of the brain. There is no flow at all at the carotid at its fork. There is no flow in the left side and also on the right side. And you can able to see there is a little bit slight collaterals around the peripheries. In the posterior region, it is more collaterals are seen, whereas in the anterior region, the frontal and the parietal region, there is no collaterals at all. So next slide. So at this point, you can see able to see that the both carotids are occluded. That means there is no flow beyond that, but a little bit tricky of flows are there. It is some collaterals from the periphery and dural vessels are there. So at this point, what you are going to do? So the patient presented out of the thrombolysis window, but he presented with a thrombectomy window. So what you are going to do? This patient is going to have left ICA occlusion. So what you are going to do? Now the patient is not willing for any procedures. So we go ahead with the CT angio. Next slide, please, Krishna. So CT angio show the same. You can able to see the base of the carotids. Both the carotids are occluded and little bit thrombus on the left carotid. And along with there is a tiny tricky flow over the AC and MCA territories with minimal small tributaries like vessels are there. So, but it is not enough to supply the whole brain. So next picture. So in this stage, we advise we want to need for revascularization of the occluded vessel. As it is a thrombus is evident, we want to we want to remove the thrombus, but the patients and attendants are not willing as because the patient is well at the presentation. She is able to move little bit. She can able to walk with support. That's why they no need to go with the thrombectomy procedure. So anyhow, we explained about the need of revascularization. At the same time, we are able to manage the low molecular weight heparin and dual antiplatelet and statins. On day 2, next slide, Krishna. That means after 32 hours of presentation, patient developed an episode of generalized tonic-clonic seizure, followed by complete motor aphasia and right dense hemiplegia. So patient worsens scenarios. Now we clinically suspect to have evolving stroke with an ongoing window for the thrombectomy. So now we asked the attenders and about the procedures, and we talked about the procedure and the complications. They accepted for the same. So next, Krishna. So this is a follow-up MRI which shows acute basal ganglia infarct which was evolved over the other areas of the frontal regions, and you can able to see the tiny embolic infarcts over that areas. Krishna, next slide, Krishna. The MRI also show the same picture. The left ICI is occluded, which was more evident at now. Next, Krishna. So this is a DSA picture. We can able to see the right eye MC occlusion at the origin. Next, Krishna. Next. Left MC also occluded with the thrombus. So what we did a mechanical thrombectomy with angioplasty and stenting. So we did it with the balloon angioplasty, balloon dilatation followed by stenting was done. Then next, Krishna. Post balloon and stenting, patient has a reformed flow that post plastic injection shows. The next, Krishna. Next. So you can able to see the blood vessels, which is not as seen before. It is looks like normal vessels. That is after revascularization. Okay, next, Krishna. So this patient actually is he presented with acute left ICA occlusion at the origin. Yeah, that is inside the skull. So clinical radiologically, the patient suspected to have Moyamoya disease. As per the imaging picture, the base of the carotid fork involved, it means a Moyamoya always. So what we did a NA profile as the patient is young. We can able to detect some SSA antigen was positive and see detected to have B12 deficiency and the hyperhomocysteemia, which is the cause for her stroke. And also we have genomic test we did. It shows a sodium channel mutation that was positive. That is also not correlating properly with the Moyamoya disease. Some patients you may have stroke with the sodium channel mutation, but don't have Moyamoya pictures like this patient. So what the diagnosis we made was a case of acquired autoimmune Sjogren vasculopathy presenting as Moyamoya syndrome with the bilateral ICA occlusion. Patient underwent mechanical thrombectomy and left MC angioplasty and stenting. The patient improved very well. Next, Krishna. The motor aphasia improving in the power of the right upper and lower limb muscle 4/5. The patient walks with minimal support. Next. So it is a case of Moyamoya syndrome. Actually, it is not a Moyamoya disease as seen in the genetic patients. It is a Moyamoya syndrome presented as a acquired vasculopathy. So for some salient features of Moyamoya disease. Moyamoya disease is a progressive vascular disorder affecting the base of the brain where the carotid arteries are more involved. So what will happen? There is a progressive occlusion of the vessel. In order to prevent the progressive occlusion, the tiny blood vessels are formed over the brain in order to supply the blood to the brain. So instead, the blood vessels are tiny, smoky appearance, which is called Moyamoya vessel. Tiny vessels are called Moyamoya vessels. Next, Krishna. So the pathophysiology shows there is a fibrocellular thickening of the intima and irregular disruption of the internal elastic lamina and attenuation of the media are the main findings in Moyamoya disease. Next, Krishna. Usually, it has a 6 progressive stages of pathological progression. That's the progression of the disease. It usually starts with the narrowing of the carotid arteries, followed by Moyamoya vessel origin at the base of the brain, followed by increased collateral vessels from the scalp, and followed by the narrowing of the internal carotid artery and complete blockage of the internal carotid artery and complete disappearance of the all vessels of the Moyamoya. Only the external bypass circulation will be appeared during the end stage. Next slide. Next, this is a DSA grading for the Moyamoya. There are 6 stages, stage 1, 2, 3. You can see the stage 1, there is narrowing of carotid fork, and stage 2, there is a Moyamoya vasculopathy is appearing, that is Moyamoya vessels are appearing. And stage 3, there is intensification of the Moyamoya vessels. Next slide, Krishna. Stage 4, there is minimization of Moyamoya vessels. That means they are able to disappear. And the stage 5, there is a bypass from the external carotid artery. And stage 6, all the vessels are disappear. Only external carotid artery is going to supply the brain. This is 6 stages of Moyamoya. Next slide, Krishna. So etiology usually genetic. The RNF213 is a factor which is play a major role in people of Japanese origin in Moyamoya disease. Some autoimmune triggers are noted, as like our case, we have a Sjogren syndrome presenting as a bilateral carotid stenosis presenting as a Moyamoya disease. So other several diseases are associated with the Moyamoya changes like neurofibroma, sickle cell disease, Down syndrome, or otherwise we can see in patients with radiation and radiotherapy to head and neck cancers. Next, Krishna. So treatment, usually the Moyamoya have only the external bypass surgery is a treatment option. For acquired Moyamoya, we have a lot of treatment options like antiplatelets, aspirin, and steroids plays a major role in inflammatory vasculopathy like our case. And vascular interventions like mechanical thrombectomy and stenting angioplasty is in selected cases give a vital to the patient's recovery, so as like in our case. And surgical therapy. I already told in the genetic cases, we can go with the surgical therapy. So next slide, Krishna. Surgical therapy like direct bypass surgery, that is superior temporal artery is bypass with the MCA. Next. And encephalomyosin angiogenesis and omental transplantation. These are the procedures. It's documented for the Moyamoya disease, but nowadays these are the procedures that are not doing very well, but only on some centers are doing this because of these neuro interventions. Next. So these are the reference. Next, Krishna. These are the references quoted by me for your references. And I directly go to the case number 2. Yes. So he's a case 2. He present, he's 84 years.
So Veda,
Hello,
please
sir.
hold on.
Yes,
That's
sir.
a very interesting case. Instead of mixing up two cases, I think
Yes,
we
sir.
can initiate some discussion on the first and then go
Yes,
for the
yes, sure.
second case. This is what
Sure. That's nice.
Balu, do you agree? Balu, madam?
Yes, that's right, sir.
I think that we can have a discussion on this. It's a very interesting case which you presented. Let me ask you with my opening question. Now, we
Yes,
had
sir.
a patient where it's very out of the box from
Sir,
32
voice,
hours.
voice are
You shared
breaking.
of you have shown us the experience of doing mechanical thrombectomy at 32 hours. In fact, we have a thrombectomy for a basilar case, not an anterior circulation case like you.
Yes,
Beyond
sir.
36, 48 hours we have done. But this
Yes,
is the
yes.
first time I'm listening to a 32-hour window for a. So it tells us that the tissue window is most important. The point I would like to ask you a couple of questions. First is that at the time of presentation, you showed us a diffusion. Was
Yes,
there a
sir.
diffusion flare mismatch? What was the diffusion?
Yes, sir.
And why we did not consider diffusion flare?
Sir,
This was my first question.
yes, sir. There is a mismatch was there, sir. The patient is, sir, am I audible, sir?
Yes,
Your
you are
voice are,
not.
yes, yes. So actually, the first presentation, the first initial day, first day, he presented with the acute infarct. That time also he has a mismatch, diffusion flare mismatch. That time also we asked him for the thrombectomy. Even the patient is not willing. Next day we did again the ongoing stroke was there. So ongoing stroke also has some mismatch. The next day also the patient has a mismatch. Again we did a MRI and we find to have that mismatch. The perfusion tissue is available and penumbra is still available. So we did a thrombectomy as because of mismatch, not because of hours. We didn't calculate the hours for the press. Yes,
Can
sir.
you show that image to us? Like we're interested in seeing which mismatch you took at the end of time. Was it a perfusion based study you took, or was
Yes,
it
sir.
based on only flare you took?
Yes, sir. Perfusion study we did. Perfusion study we did. Flare mismatch
MRI,
also we taken up.
MRI or CT perfusion?
The MRI perfusion. MRI perfusion.
Do you have the image to share with us? It would be interesting for viewers to see the data.
Oh, actually, I will share it after the discussion, sir. I will definitely
Yeah.
will share you. So as actually
That's a
this
very
case was,
important
mama, I will share to you, sir.
because beyond 6 hours, whenever we have to take up a patient for a mechanical procedure, we always want to see the salvageable brain. And
Yes,
there are two ways to look. One is the CD perfusion, MR perfusion studies, but perfusion studies sometimes do not give us the accurate data because
yes,
perfusion studies are quite variable. They are going to really, this is a snapshot wherein sometimes because scope is dynamic, you can have times when you overrate the perfusion and the times you can underrate the perfusion. So because of that, we'd like to see exactly what was happening at the time for us to base our data for this. The reason why I wanted to. In our hospital nowadays, we do straight away with ASL perfusion. We go. We find
okay,
it
okay,
quite matching because perfusion studies, but definitely we have to give a contrast of both. It's interesting to see that data. That was my first question in this. And the second thing was that we'll also want to see the images post thrombectomy, how he was doing, and the NIHSS pre-stroke and post-stroke. Can you share the data with us, Dr. Veda?
yes, sir. I give all the data,
What are the
but
NIHSS
sir, pre-stroke one, he has a 7/42. 7 by
pre-thrombolysis?
4 pre-thrombolysis. Post-stroke, after a month, the patient has a 5/42. And after now the third month over, now he has only 2/42. Mild dysarthria is there. Otherwise, everything is fine. And she is doing very well after 3 months of post-thrombectomy status.
The reason why
I will share your perfusion image and the MRI perfusion. Everything I will share to you, sir. As because of gross mismatch between the perfusion and the perfusion mismatch. That way we did a thrombectomy. Unless otherwise we don't touch that patient as because patient is worsening again and again. We try to give a compensation by calculating the mismatch between the penumbra and there is two mismatches has been we documented there. Diffusion perfusion mismatch also there and diffusion flare mismatch also there. That's why we did a case. And luckily we got a good outcome.
Clinical data is too small for this infarct which you showed. This is the reason why I asked you. So
Oh,
sudden the infarct was quite even easy to get away with it in the like
yes,
Dr.
sir.
Balu and Dr. Titan, Dr. Balu
SMS,
has
your voice is breaking. It is like
Ama.
an intermittent flow. It is a slow flow.
sorry, Balu.
Madam is there.
Because it
Your
is
voice
no,
is
no,
very
Balu, it is
low.
coming from
Madam is by your side. Why your voice is very low? It's not. You're not able to
not
hear.
because of it, Balu. Because it is a mobile phone I'm using, Balu. I'm talking to them outside, not using Wi-Fi today. Yes, Balu, let me listen.
Sir, you can turn off your video so it will be better.
I switched off my video, Amit. Let me listen to Balu. Yeah. Balu Kaitan, madam. Yeah. Your thoughts on this case, Balu?
Yes, madam. Kavita, madam. Yes, madam. Yes.
Yes, sir. Thanks. So actually, very interesting presentation. My question was, how much, how are we justified in, I mean, naming this as an acquired moya moya? Because one thing is, what about the collateral grading? Another one is, could it be a vasculitis, just a vasculitis coexisting, or due to a Sjogren's? That was the etiology, I guess, was diagnosed in this case. So that was the question I wanted to ask, because considering the age of the patient and the DSA picture and the collateral grading, based on that, are we justified in calling this as an acquired moya moya, or it is just a cerebral vasculitis, or a vessel wall imaging was done for this patient?
Yes, madam, I try to answer. And actually, the moya moya is a disease of basal carotid occlusion. So, this patient is having basal carotid occlusion that is termed as a moya moya. But exactly the patient doesn't have any vascular pathology as like moya moya, like fibrocellular cartilaginous deposition and the intima-elastic lamina deposition. That was not there in our patient in the CT guided vessel imaging. And also, we did a MRA angiogram. And also in the neck vessels also we screen for that vessel pathology, the eccentric wall thickening or a concentric wall thickening, everything looked there. But there was no demarcated pathology was not detectable in our MRI. We didn't do the biopsy for confirm it whether it is a CNS vasculitis presenting as moya moya. We don't know. And this patient also doesn't have any other Sjogren's features. Only the Sjogren's antibody is positive. Whether we don't know whether it is a false positive or false negative, we don't know. Exactly, we don't know. But other parameters like renal involvement, lung involvement, liver involvement, which was not there in our patients, which again points against our diagnosis of Sjogren's. So usually Sjogren's will present with other symptoms. CNS Sjogren's very rare to get at only the both carotids involving, not other vessels are not involved, no other cranial features, no other neurological involvement. It is very rare case. The problem is we have to do the biopsy of the vessels, either the carotid vessels or the something else. We can came to make a diagnosis. And the PET also we are not able to do because as it is very costly. And PET scan what we expect is we want to locate the vasculitic features, and also we want to do the um, um, to rule out the RCVS. Sometimes RCVS can present with these features, but there is no clinical association between the RCVS and these our patients. So actually, it's a mixture of cases. SC presented with the moya moya like features in radiologically and clinically, and it's termed as acquired moya moya, and probably related to the autoimmunity, probably Sjogren's positive. So repeat Sjogren's also came as positive. After 3 months also we did a Sjogren's test. Even after steroids, he has a positive. So positive titers. So it means he has some autoimmunity. So autoimmunity associated moya moya syndrome. Like that we can term it as. I am not calling it as moya moya. It is autoimmunity associated moya moya. So anyhow, the Bala sir, sorry, SMS sir is asking me about that perfusion mismatch image I will send to him and also send to you. So you can see we can able to perceive the difference between the flare mismatch and the diffusion surface mismatch. It was definitely there. That's why we did a thrombectomy. Unless it is after 32 hours, nobody will do the thrombectomy. As per the indication, only 24 hours is available for us to do the thrombectomy or other things. So nice, interesting case for me to present here.
Dr. Veda, we never
Sir.
doubted that you did it. We wanted you to show our viewers what you have done. That is all.
Yes, sir, sure,
Know that
definitely.
100% you have done that was very obvious to us. Otherwise, your interventions would not touch it. I just wanted you to share that images for everyone to see, not for me.
Yes, sir, sure, definitely, sir, definitely. Yes, yes.
Bala,
I have images, sir, but I am unable to share now
no problem,
because
Dr. Bala, your views on this.
It's eye-opening. He has opened the vessels and he has opened the eyes also beyond the window, beyond the thrombosis window, beyond the thrombectomy window. It's all individual case based. I should congratulate Veda for taking up this case and then presenting and then showing us an interesting case. Number one, and as he rightly said, he wanted to show it's a Moya syndrome. That's all. So that could be a secondary Moya. That could be commonly. I thought that when he was selling Moya, probably he was selling that from Coimbatore, probably from Ooty. We could see that secondary Moya of sickle cell. So I think probably you might be seeing more sickle cell in your area and sickle cell related Moya also you might have seen that. Sjogren without any other extracranial, that means pure Sjogrens, what do you call that? They can have without any other systemic manifestations, pure
Sjogrens.
CNS Sjogrens or neurosjogrens. That's a new entity there, like neurosarcoid, neurosjogrens, neurobetches, like that. So it's possible people can have, but we recently had one patient had like a repeated stroke, and we had to go with the high dose of steroid, and then that's the way that we managed. And that patient had obvious signs of other inflammatory process like a headache and CSF pleocytosis. There's all the clues in that patient. But your case is a little bit different. But angio-wise is Maya. That what you can say, the combination of the criteria for Maya for angio-wise bilateral carotid, the terminal carotid being occluded. It's a wonderful case. And then in the Sjogren, when you say that, you can go ahead with, when you have a doubt about the serological things. We see Sjogren 1+ in most of the NMO also, neuromyelitis optic also.
Yes.
And in the situations, if you want, you can go with the lip biopsy. The scorings are there. That's the only thing. That's my suggestion, because if it is a Sjogren, you have to add as a steroid and immunomodulators in this case to prevent the recurrence. I think it's a straightforward now. Looking back with over the follow-up of 3 months, not having any of the manifestation of systemic vasculitis or CNS vasculitis, you have dealt with a very rare presentation of Sjogren or some autoimmune disease with Moya-like symptom. Thank you, Veda. Very, very interesting case.
Thank you, sir.
Thank you, Dr. Veda. Really interesting, and as Balu said, eye-opening case. We read about Moya coming to the emergencies and thrombolizing, but this is the first time. And I hope that thrombectomy after 32 hours.
Yes, sir. Sir, that's one more thing.
Sickle cell induced in your place, because we don't see sickle cell in our area.
Yes, sir. Here it's more common. Sickle cell disease are more common, as because some OT people are coming down, sir. They have more vasculopathies, like sickle cell presenting as lacunar stroke and large vessel occlusion. Everything they have, sir. So, but we didn't. No, but the same time.
Yeah, and in the follow-up also, you need to keep them under close follow-up, because the next worry you are going to have is hemorrhage. Because the Moya vessels, which are actually very thin, are going to go for bleeding. So follow-up is going to be quite challenging. And definitely for this age, we'll go only for the direct vascularization, ST and bypass. The EDMAS people are not doing, because indirect is not as effective, and it is useful in children where you do not have a lot of space and a lot of area to operate upon. In adults, we straight away go for actually ST and bypass. Thank you very much. It's a very interesting case, because my teacher, Dr. K. Srinivasan, it's his pet case, actually. He talks so much about this. And thank you for showing the Suzuki grading also to us. Thank you. I think we'll go to the next case. Dr. Balu, madam, Kavita can go to the next case, madam.
Yes, sir. We'll go to the next case.
Thank you, Dr. Veda. Next, we are
Sir,
waiting
thank
for
you, sir. Thank
warm cell
Sir,
problem.
the 32 hours, as I put, sir, as because the patient is ongoing stroke, even at presentation, sir. First stroke presented, not thrombolized or not intervened. But at the same time, the patient next day developed GTCS. That was, again, the window period is changes again and again. So, that is also there, sir.
See, the point is that today
As
the
like,
treatment has shifted from time-based thrombolysis to tissue-based thrombolysis. Absolutely okay.
yes.
24 hours is after all a number. 24 could be
Ah.
25, 25 could be 32, and this time is going to be variable. I know
Yes,
there are
sir, yes.
ongoing trials to see whether we can do some more things to actually extend this thrombolytic window, but that should be seen in the future. As of now, we stay with this. Excellent case.
Yes,
We'll
yes,
go to
sure,
the next
sure.
case, Doctor. We're waiting for your next case.
Thank you, sir. Thank you. Sir, thank you, sir. Thank you. Krishna, can you share me?
Yes, sir, I am sharing. Just a second.
There's as like second case. The first case we had a seizure. As we not thrombolized the case, and the patient developed evolving stroke and seizure. The second case is in a reverse. The patient presented with the dysarthria and a right upper limb weakness. The stroke window is 4 hours. The NHS for 5, and we did a thrombolysis. Next slide. You can see that embolic cortical infarct, that is small lacunar cortical infarct over the frontoparietal and parieto-occipital junctions. That means the watershed infarcts. I'm sorry for this showing this flare image, which is not coherent with diffusion image, but there is a mild, subtle flare mismatch was there. The image is not good. Sorry for that. Next slide, Krishna. And this is there is no large vessel occlusion of this patient. Next slide, Krishna. So the post thrombolysis, after 1 hour, the patient developed status epilepticus. He started with the right focal seizure with loss of awareness, and finally it leads to status epilepticus. He was in seizure for more than half an hour. So immediate CT was done. It showed no bleed, and the status was managed effectively with the medications. And we made a diagnosis of early post-stroke seizure following thrombolysis. It is a kind term as per the literature we have given here. So let us see about some points about post-stroke seizure following thrombolysis. Next slide. So early post-stroke seizures are very uncommon, and early post-stroke seizures are common within first 7 days after thrombolysis. Even though it is uncommon, it is the first 3 days is more common for getting early post-stroke seizure. And the late onset seizures beyond 1 week is very less frequent. So actually, the thrombolysis doesn't appear to markedly increase the risk of early seizures compared to the overall risk of seizures following ischemic stroke. That means the thrombolysis doesn't relate to the seizure risk. And the seizure type, usually the post-stroke thrombolysis seizures will be generalized tonic-clonic seizure or focal seizures with impaired awareness, as our like case. Next slide, Krishna. The risk factors for post-stroke seizures are cortical involvement, hemorrhagic transformation, infarct volume, it is more than 60 ml, and reduced APTT. That is, some cases, some publication shows that a reduced APTT level has been associated with the post-stroke seizures. Next, Krishna. So, mechanism for post-stroke seizures following tenecteplase, the sudden change in cerebral perfusion, which might associate with the inflammatory response followed by reperfusion syndrome, that leads to seizure and post-stroke epilepsy. That is a hypothetical explanation for the post-stroke seizures. Next, Krishna. In spite of the earlier evidences that seizures might be a sign of successful reperfusion, that shows the seizure after strokes are associated with poor outcome. And the greater risk of seizure in patients with malignant middle cerebral artery are reduced with tenecteplase. Hence, the reperfusion therapy saves the neural tissue, and the chance of post-stroke epilepsy decreases after thrombolysis. These are the one more hypothesis that shown that if you thrombolyze, you may have less chance of to get post-stroke seizures. That is also accepted here. Next slide, Krishna. So take-home point here is don't hesitate to do thrombolysis or thrombectomy in view of post-stroke seizures, which can be managed very effectively with the drugs. And post-stroke seizures following tenecteplase are very uncommon and are better manageable. So if the stroke patients come to you, we must find a reason to thrombolyze and admit the practical difficulties and decanalize the vessel in order to save the patients. Thank you, sir. Next slide. Yes. Thank you, sir.
Thank you. The first presentation, was there any history of stroke at seizure at home? Because
no, sir, no.
sometimes the attenders may not be aware the person had a seizure, and they come with post-stroke weakness. And
Yes,
we
sure,
evaluate
sure.
the patient, and then by the time we plan for thrombolysis, they improve. We may think that's a TA because one of the common stroke mimic, the most common stroke mimic being seizures in both younger age group and senior citizens. And there was one recent article. The
Yes, sir.
radiologist made the diagnosis of seizure
Oh,
by looking at the
MRI.
MRI. So
Oh, yes.
that was interesting thing that the radiologist made the diagnosis because they looked at the tongue. There was a tongue injury in the cases, and then they said that 7 patients of coma undiagnosed turned out to be seizure diagnosed by the radiologist.
Sure,
So
sure.
we might have heard about seizure diagnosed clinically, diagnosed EEG, but first time I saw the article diagnosed by radiologist by MRI. So
Sure.
that also can happen. So after that, I started looking at all the patients of elderly citizens having at that's one tongue cut, may tongue
Yes,
tell us.
yes, sir, yes, sir.
Sure.
I actually, sir, actually, this patient is my relative.
Okay.
My sister-in-law, my sister's father-in-law. So very well known to me. Immediately after the presentation, they arrived at me, and there is no seizure activity during the course
So
of shifting. Probably, sir. Maybe the attendant is a layperson, may not known about that. But there is no active seizure. There is no history of active seizures.
on a lighter note, you have to take. My professor used to say that when your friends bring their father-in-law to you, that's different. When their friends bring their parents to you, that means they believe in you. When they
Uh,
their father-in-law, mother-in-law to you, that means they don't believe in you. On a lighter vein, you have to take.
sure, sure, sure. Sure, sir.
Yes,
Thank you,
SMS.
Dr. Bob. That is really incisive comments. We'll wait for Madam Kavita to give her comments. Thank you.
No, sir, I think no, no, just I think that's a wonderful presentation, both the cases, Dr. Vedna. I think this
Thank you.
is and a very practical problem we face. And as you rightly said, after tenecteplase, it's very, very less. And the incidence of seizures. And now talking about the post thrombolysis complications, sir, it's my personal doubt about, I mean, at least can we have a discussion about post thrombolysis, a sudden hypotension on
Yes, ma'am.
pulmonary edema, the patients develops, sir. So the thoughts from my seniors and my
First thing
colleagues.
is that any patients having sudden hypertension, we are trying to look at the cardiac tamponade.
Correct.
Number one. That's the only thing that first thing had to come in our mind. So sudden hypotension. So just look at the whether you can put that echo and then you can make the diagnosis of whether there's a bleed in the pericardium. Second one, the person is having pulmonary edema. Whether it's a really pulmonary edema or cider-like the angioneuritic edema. The tenecteplase, we recently saw one case of angioneuritic edema affecting the tongue swelling on only one side. We didn't know that why, but that the hemiplegic side had a unilateral angioneuritic edema. That's we have written the paper. We are on the process of publishing it as unilateral. So these are the two things. One is reaction, allergic reaction. The second would be a severe allergic reaction, angioneuritic. The most deadly would be of pericardial, that means hemopericardium. And the third one could be MI. The person having MI.
Coexisting MI, which should have been.
One more event. So one vascular event, one more vascular event. But when a person has both MI and stroke within 24 hours, the prognosis is really bad unless we go for a mechanical thrombectomy or PTC.
Yes.
So we had 6 cases. All 6 patients we lost within a week of on the same day, 24 hours. So the only one person survived. That person straight away they took the patient to cath lab. Thrombectomy was done, and PTC was also done. So I always say that this is a deadly combo. What happened to your patient, madam? Your case, what was the final diagnosis?
The actually post thrombolysis, we actually could not revive the patient because the patient had a cardiac tamponade, sir.
Okay.
Developed a cardiac tamponade because it was a very rare episode in our place, because thrombolysis, especially with tenecteplase, we didn't have these. Probably that was a cardiac event which was coexisting in that patient.
Probably the recent transmural MI would have precipitated that. So that a transmural MI, a necrotic area, would have precipitated that event. Otherwise, very rare, very rare. We don't see most of the time bleed with the tenectic place.
There are a lot of discussions also about post thrombolysis positioning of the head.
Yeah.
Is that
So
there have been
whether
discussions?
from my institute protocol is that flat. We don't
Flat,
keep that
yes.
flat. We don't keep that.
They have read papers where post thrombolysis, because I don't know about the seizures. Probably the head flat or head up position. Does it really have so much of impact, or it's just a
But
coincidence?
I don't know the scientific outcome. But in our hospital, the protocol is that keep flat. So
Keep it flat.
so psychologically, we are better.
Madam, there was a trial on this, madam. There was a trial called head post trial.
Yes.
Now the idea is like head post trial. There's a trial on the positioning of patients following stroke, not specifically referring to thrombolysis, but talking about the
aspiration
stroke patients in general. Now you are weighing down the risk. They're weighing the risk between aspiration rated events versus improving the cerebral perfusion. It does increase. I think the tune of almost 15%, if I remember. It does increase when you make the patients flat. That's an advantage you gain at the cost of time. So now the accepted thing is to go for 15 degree, 15 to 30 degree max. You can keep them. That is an accurate compromise between aspiration risk versus cerebral perfusion. This trial is available in the net.
Practically, when you don't see dense hemiplegia, the chance of aspiration is less. In the situation, you can go flat.
Yeah.
So you have the dense hemiplegia, definitely aspiration chances are high. If they have that mild dysarthria, clumsy hand, ataxic hemiparesis, and that's all the cases that we can do that. So thank you, SMS.
Coming to this case, Dr. Veda, again,
Yes,
nice
sir.
case. There are a few takeaways. Now, when you look at the very early data NINS2 trial, those were designed for a particular purpose when they used to say seizures were a contraindication for thrombolysis. It no
Yes,
more
sir.
is a contraindication.
Yes, sir.
That is the first point we need to remember.
Yes,
Those
sir.
parameters were kept for a purpose of conducting a trial to have uniformity. And talked about the post-ictal deficits. We don't care at all whether they are seizures at the presentation or not. We don't really worry about it because now we are doing tissue-based thrombolysis in most of them. That's the first point. And the second point is that occurrence of seizures post-thrombolysis is no different from patients who are not thrombolyzed. So a fear of seizure must not make us not thrombolyze. That's the next important point we need to remember. In this patient, you showed cortical infarct. So cortical infarct are more likely embolic infarcts, and we know by definition embolic infarcts they have a higher chance of seizures. That's probably was the trigger in this patient. Nevertheless, well done, really. Whether you taught us excellent things. Balu, for want of time, can you go to the next case?
Yes, SMS.
Madam, can you go to the next case, Dr. Veda? Anything you want to teach us more?
9:15.
Can
Oh, sir.
That's the reason. Yeah, I was
You have to
waiting
teach,
for
sir.
that only.
Okay,
You can
sir.
go to the next case, sir. Thank you. You go to the next case, madam.
Good evening, sir.
Welcome, sir. Welcome.
Good evening.
Sama sir and madam.
Hello.
Good evening. I'm Dr. Jayasankar.
Namaste, sir.
I'm from Kerala. I'm in Thrissur right now. So I will straight away go with the case. Is it visible? No?
Yes, yes, yes. Slide so it has to come. Yes.
So, okay, now, sir.
Yeah, it's okay. Okay.
So basically, this is about a large core infarct which underwent a thrombectomy. So this is not a representative case, but just want to highlight the areas where we have to look into while dealing with a large core acute infarct, whether to take up for mechanical thrombectomy or not. So this patient basically we have done thrombectomy and have a good outcome. That's the thing, but it's not a representative case. But I will just discuss the case right now. She's a young female and no comorbidities so far. And at the time of presentation, she was 43-year-old. And onset was at a stroke. Onset was in the form of left sided weakness at 4 a.m. Deficit noted first at 4 a.m. And she was taken to nearby hospital, and MRI was done with MR angiogram, where she was thrombolized and referred to this hospital. And she came at 8:10 a.m. That is around 4 hours of window after thrombolysis. Excuse me. Yes. So at the time of presentation, she was having a dense left-sided weakness with the cortical sign, hemi-neglect, and gaze preference. And she was having a UMN facial palsy. So the NIHS was around 18, up to 18, between 60, maybe between 16 and 18. It was a high NIHS stroke who has undergone thrombolysis from outside hospital. So this was the MRI films available from the outside hospital. This is diffusion restricted, diffusion weighted imaging. We are having a right hemispherical large infarct in the MCA and ACA territory. We can see, even though it is only 4-hour window, the infarction is progressing. So she is basically a fast progressor to have diffusion restriction changes, which is uniform in the right MCA and ACA territory. MCA territory is more affected, with the upper part being relatively spared, but it has involved the basic ganglia, the cortex, in the lower cuts. Higher cuts also involvement is there, but maybe less dense than the lower part. So the aspect was very low, and it is large volume, large core infarct. As per diffusion core assessment, so the aspect was 2. In the FLAIR imaging, it is consistent with the 4-hour window. There is subtle effacement of the sulcus in the involved territory, but frank hyperintensity in the either in the cortical or subcortical structures was not there. So there was earliest change was there. And if you see the vessels, you can see preserved fluid in the distal ICA, but MCA branches was hyperintense. That means either the blood is either very slow or stagnant blood is there in the right MCA branches. ACA, we didn't see any hyperintensity. So there was significant flow reduction or loss of flow in the MCA branches with almost 4-hour tissue window, consistent with the presentation. But diffusion was very much spreading. So she is a fast progressor within a 4-hour window. In the MR angiogram, she was having a right proximal MCA occlusion. And anterocerebral ACA up to A2 is normal. Maybe distal occlusion was there because she was having ACA infarct also. ICA was almost okay. Left side was fine. So it is a large vessel occlusion of proximal MCA, probably affecting the branches and the lenticulostriate vessels. So basically, we have assessed the patient high NIHS within window, fast progressor, and the diffusion aspect being 2 with the proximal MCA infarct. So this is the so after counseling, she was taken up for DSA to assess the collaterals and to proceed for thrombectomy. So this was the right ICA common carotid injection showing right internal carotid artery, and we can see there is an abrupt cut of the right MCA with only a small vessel coming from the MCA. Rest of the main lenticulostriate branches and the main branches M2 are not seen. And in the distal phase, we can see problem with the ACA, but collaterals coming from ACA to right MCA, but especially the upper part, consistent with the slow progression of the upper part of the MCA diffusion changes. So probably this area is not much, not having much of collaterals. Upper part is having some collaterals. So we counsel the patient since it is large score and young, so definitely she will need decompression. Before that, an option of opening the vessel was given, and we planned for an opening fast since she is a fast progressor. So a fast mechanical thrombectomy if possible. We planned. So in next almost 20 minutes, we achieved almost sticky 2B recanalization in right MCA with almost good perfusion in the right MCA. But there is some decreased perfusion in this area, maybe due to occlusion of the distal branches or the distal ACA territory. So this was at 8:42 a.m. So it is almost 4 hours 45 minutes window. So full reperfusion was done. So it was we were able to get it opened in first pass, but we are not planning for multiple passes because she is a fast progressor and probably will end up in heavy reperfusion complication. And as we expected, she was having a large infarct, and sequelae of that, she had a large edematous area in the right hemisphere, loss of the lateral ventricle got effaced, and she started to have midline shift within 8 hours after the procedure. So as we planned, we did decompression craniectomy on the right side. So this was post craniectomy. There is infarcted area in right hemisphere MCA ACA territory. This is day 10. So in day 10, the brain started to shrink and we started to see ventricles. By the time initially we gave sufficient medication for as anti-edema measures, and there was no other complications rather than the sequelae of this high NIHS infarct. This was on day 15. This was on day 15. This improvement was not that expected in her, but she became like MRS2 on day 15. Usually these patients will have a lower side of response, but since she was young, we had to have the maximum therapeutic advantage for the patient. So that's why we opted for a fast opening and fast decompression. And by the time we evaluated the cause for a stroke, and at 3 months, the MRS was almost 0. But she was having some weakness, but it was very surprising. But the response was very good. So we have done a few cases of large bore thrombectomy, and like in those patients, this is what we are doing. Like we avoid elderly patient, late presentation, then pre-stroke status, and we try to do in early window because large core late window is very bad. Large core early window, we have the time window advantage. So that's why very early window we try to do. And as this MRI diffusion aspect is very good when compared to CT aspect. In early window, we will have a better idea of the area where the patient is having ischemia, where the patient is really having this membrane instability. So it's considered to be the best thing, best modality to assess the core. And elderly, we usually don't do this. That is fast progressor patient. And always we emphasize on early decompression in this patient. If we are not able to, or if the bystanders are not willing for an early decompression, we do not do this kind of measures. If you are opening a large core, definitely we have to do decompression because many things can happen. Sudden hemorrhage will be very almost fatal. But this patient didn't have a hemorrhage, but as we expected, there was edema because she was young. So these are the trials and evidence available. The main trial is selective trial. All these trials are like 500, 800 patients, where they have shown benefit for large core thrombectomies. But we should be reading all the parameters of the patient's selection criteria and all. For example, in Select 2 trial, which is the most commonly discussed trial for large core thrombectomy, have an aspect of 3 to 5, average score of 50 ml, median window of 9 hours, median core volume like 74, median NH is 19. So these are the values you should be knowing whenever, like you cannot straight away take up large core thrombectomy. And all these trials, like these are the final details of Select 2 trial, in which we can see that the median volume of tissue with the Tmax more than 10 seconds is almost 100, and the core is almost like 70. So a large core means more than 50. So average core size in this trial is almost 70. So the difference was almost 100 in average. So that value you should remember if you are taking up the case, because even in large core thrombectomy, this perfusion mismatch is very difficult to assess because already core is very large. So we are trying to perfuse the core more than the penumbra. But still, this 30 ml may be significant. Difference may be significant. And other trials are Rescue Japan trial. We can go through that. Then Angel Aspect trial and Tension trial. These are the main trials. And recommendations, some comments was there, not frank formal recommendation is there for large core thrombectomy. Recently in 2025, HASA has a strong endorsement in a 2025 advisory where selection like aspect less than 5 or more than 70 based on the trial criteria can be used as a selection criteria for taking up a large core thrombectomy. And SVAN has commented, ESO has commented, and in national guidelines in UK, they also support like trial aligned criteria for selecting this large vessel. So formal, this is not there, but almost a class 2A, this thing is there. So as far as we are concerned, like imaging, we will thoroughly check, and age, we will check young patients. Then core is less than 100, averaging up to 74. Then window, then immediate anti-edema measures, immediate decompressive craniectomy to maximize the yield. because this reperfusion hemorrhage will happen like 2 to 3 hours after reperfusion, not immediately. So an immediate CT or a late CT won't be helping you. So like we have to take a CT like 1 hour, then 6 hour, then 12 hours for a large core. So it is always better to go for a craniectomy if the patient is young, and especially if it is a right side, because this patient was a right-sided stroke. So these memory, the most of the cognition was preserved. It will help in the recovery, the physiotherapy, everything, every aspect it will help. So like if it is right side, young patient and carefully selected patient will have a good outcome. So since, but still it is a vague area. So thank you, sir.
Very nice and extensive discussion also on this case, Dr. Jaishankar. You come from the place where a great guru of myself and Balmurugan is sitting. You come from the place of Dr. Haridas, right? So
Uh,
convey our
VT
respects and
Haridas.
regards to Dr. Hari. So he's our great guru. That's first point. And there's a very, very interesting aspect you brought to the forefront, talking about the large core infarct. That's a really challenging event for all of us. So we have, so how much we are going to extrapolate the Western, data into us. But this was a real success for you because that despite having a huge core, probably because the tissue was salvaged, you went ahead very quickly and did everything. You are having an excellent result in that the patient was able to walk there. So I'll open this discussion for my colleagues, and then we'll have come back. There is another case which has another question that's been put in the chat box. We'll address that at the end. Okay, the stage is yours, Balu and Kavita Madam. Dr. Balu, your comments on this, Balu.
താങ്കളുടെ അവതരണം അതിപ്രശംസനീയമാണ്. Wonderful, wonderful presentation. Okay, and really, as your SMS said, that the large core, how do you that, and then the early decompression that we are insisting this for the past 20 years, early decompression, and we generally feel a little bit hesitant when doing a decompression, especially when the person is having a left hemispheric large core and then having aphasia. But there are some of the patients who improve, and when they come for the follow-up, we wonder whether we could survive with half brain. So that much totally removed, totally destroyed half brain, but they could manage with without any stick. They could walk. And it's highly variable neuroplasticity. I agree with the presenter, and but both the cases what you present is very nice, and thank you. And any other take from Professor?
Yeah. Madam, Kavita Madam.
I think that's a very extensively discussed case. Probably a picture perfect stroke thrombectomy, and as far as still the outcome is concerned, I think everything was so perfect in this case scenario which was present. Very reassuring to go ahead, be aggressive in large vessel occlusive cases, thrombectomy and early decompression. I think it's a wonderful presentation.
Dr. Jaishankar, I have my views also. See, when you look at the data which comes from the West, there are 4 trials you quoted in addition to Tesla and last day trial. So the meta-analysis shows that definitely there is good improvement in taking up this large core. I'm talking about the large core and not the extreme large core. Your case is, borderline between large core and extreme
Yes,
large
sir.
core
Yes, sir.
too. So in that, if you look at that, the functional independence, the NNT, when you look at that, it's around 4.7, if I'm right, for the achievement of an ordinal shift on the MRS, and it is 10, I believe, for the shift to MRS 2, which is the thing which you have exactly achieved in your case. In fact, not just MRS2, you have gone and showed us that it is not MRS2 at the end of 3 months. When you look at that, it is MRS almost 0 or 1. That's a phenomenal achievement. And there are 2 important messages we learned from you. The first thing is that when you take up the large core, go for only the young ones. Even in the meta-analysis, those patients who improved were the ones who were actually young. The older they were, they didn't do well. So that is an important message you told us. And the early you do it, the better are the results. You have to take up early. These are the 2 important key things which you taught us in this case. Nevertheless, there is a word of caution for people who are going for, these, big stuff, I should say big stuff, because it's a big giant leap. The reason is because our economy is driven by patients first, whereas in the West, many times it is insurance based. It is very difficult to upfront talk about expense of this. Exactly in our hospital, the first charge for both will be nearly 4 to 5 lakhs. Am I correct? Is that the
Yes,
cost would
sir.
have talked to them about? So minimum a mechanical thrombectomy plus hemicraniectomy and then stay in the ICU. Upfront in the first couple of days is going to be 5 lakhs.
Yes,
And
sir.
the patients actually will look for the results at the end of the day. So nobody is going to have a perception of how they might have been have they not been put to this procedure. That
Mm,
perception of what could have happened never stays with patients. What they
mm.
actually see is what they can see. We
Yes.
spend 5 lakhs, still the patient is left with a large deficit, and in fact, on the left side, speech has not come back. So, that is a huge lacuna in our society. So, at this point of time, I'm not really sure how much we can
Mm.
extrapolate this
Yes,
into
sir.
our practice, really. That's what my own
Yes,
view
sir.
is there, but that should not, cloud your opinion or judgment rather. And you have shown what you actually done because you have proved it against what we can think of. You have proved that in a young patient like this, you went ahead and did that and showed excellent results. In fact, when I saw the diffusion image, I was really taken aback. Huge infarct, really. It
Yes.
requires a lot of bravery to take up that case and actually produce the result. And many congratulations. So, the key point is that large core infarcts can be taken up for mechanical thrombectomy. Number two, we should upfront talk to them about decompression also. No pointing in doing it and coming out and then feeling sorry about it. So, both procedures patients are willing, probably maybe that's not a recommendation as of now, but it is reasonable to suggest that both procedures patients should be willing, the cost should be patients should be willing, and the adverse outcomes, if it could have happened, or also should be explained to the family. If these things go hand in hand, then I think we should go ahead for large core infarcts also. That is the message I learned from you. Balu, is that correct, Balu, madam?
Yes, sir. Absolutely right.
Highly individualized therapy, and because this is a wonderful outcome that what he had, and we all might have experienced some of the patients whom we might have thought that this patient may not come out with a large infarct, and they come out, and that's the thing I told them. I have one patient is absolutely asymptomatic now. When I do the scan and the scan shows only one, that means only half hemisphere is intact. The other one is gone, a large MC infarct. So, but there's no deficit at all. So, off brain is enough SMS.
Plasticity of the
Use
brain
less
should
of
take
them.
the credit.
And
In
it's
fact,
very
we use
different
less
among
in
patient,
some.
I think. Like
Highly varied,
uh, even in young
individual.
patient.
Yeah.
Yes, sir.
Yes, sir.
And
Yes,
that,
please, sir. Please, sir. Please go ahead, sir.
yeah. Dr. Jayashek, please tell us, you're telling something. Yeah.
Yeah, sir. Even in young patients, sir, is very very different between among the patient. Even the vasculature, the collaterals, everything. Even for distal IC occlusion, total occlusion, the core may be very small, even after 7-8 hours. And angiographically, if it is the same in the next patient, the core may be very large. So there is no consistency between patient. Only when we see image in a late window, we can be sure that how fast is the patient progressing. Like early window is always tricky. Sometimes we can't measure the outcome. But if we are doing any procedure in late window, we have the outcome in front of you before the procedure. If we are able to open, we will have a good result. If you are doing a small core thrombectomy in 10-hour window, 20-hour window, or maybe after that, if the core is very small, if the patient is having very high NHS, definitely he will going to improve. But early window, at 1 hour, 2 hour, if it is a past progressor, which we may not be knowing at the time we do thrombectomy, the results are not good, even if you do open reversal in 1 hour, 2 hour. So that's a very tricky thing we have in front of you.
I have another interesting question to ask you, sir. You have to tell us that this patient came within 4 hours, right?
Yes, sir.
Mhm.
So what made you skip IV thrombolysis in this patient?
No, sir.
Because that,
Actually, she was thrombolized from outside hospital.
oh, okay. Yeah,
Yes,
correct.
thrombolized
It was,
and
my
referred.
apologies.
Yes, sir.
Right. Okay.
And what,
And
sir?
please go ahead, please.
And regarding thrombolysis, actually, it's a very good thing. Like when once or twice, I think I have seen the clot getting dissolved just like that after we open the main vessel, and each time we do repeated angiogram, the clot will be moving distal, and finally getting fragmented out in patient who has undergone thrombolysis. Uh, so
Yeah,
once the cloud is having more surface area to get contact with the agent, I think that's the reason why it's getting once it breaks into pieces. Uh, yeah, maybe that may be the reason.
yeah. I think one of the reasons why you had a good success in this case was because patient was given IV thrombolysis prior that ensured the distal perfusion. Antiplase could have given the distal perfusion, some viability was left behind, and that's one of the reasons probably you got away with that and patient became better. That again underscores the importance of never missing out on IV thrombolysis, even when we are actually thinking of a mechanical thrombectomy and we have all the procedures, that could be done quickly and all the things available. Never skip IV thrombolysis. That's another message I think we can get from this case. And regarding the hemicraniectomy, it's interesting to know that we think that it's a very morbid procedure, especially on the left side, and what will the patient think, and whether the patient will be happy at the end of the day. There is a very interesting study on patients who were interviewed. It's an interview based analysis as to these patients who had undergone hemicraniectomy were asked a simple question: in case you have to undergo hemicraniectomy again for the contralateral side to develop a malignant MCA infarct on the opposite side, what would be a reaction? And the statistically positive results saying that they will accept the procedure on the contralateral side. That's a surprise which what you value as patients' benefit is not actually what is valued by themselves in this. That's a real study which I'm quoting. Finally, there was one question from the chat box which talked about the concept of giving anti-seizure medications with relevance to the first case, whether we should give anti-seizure medications anticipating this. The answer is that prophylactic anti-seizure medications are in fact not to be used in any setting, especially in the case of acute arterial strokes, may be questionable value in venous strokes, but in arterial strokes like this, use of prophylactic anticonvulsants are actually not a recommendation at all anywhere. This is my understanding. I'll wait for confirmation from my colleagues as well.
Yes, sir, that's the teaching there. There is no role in prophylactic anti-epileptic drug in any setting of stroke. Probably
Are
if
there
the
any other?
is a presenting feature, as you said, in an embolic infarct, probably. Otherwise, there is no role in prophylactic anti-epileptic drug.
Bali, any other questions to address, Bono?
SMS in your hospital protocol, you give all the patients 0.20 or 0.25. Do you differentiate a large vessel, suspect a large vessel versus other things in case of tenective place?
No.
You give for all
As a rule, we
0.25
give
or
only
0.20 in some of the patients?
As a rule, we give 0.25 milligram per kg weight in all our patients. The only few exceptions where we go for point, that was even before the publication of ACT data, we switched over to 0.25 mg. Way back in 2018, we switched over. So ACT data came later, but practically we switched over earlier. The 0.2 milligram we used in a very special circumstance. Whenever the patient has come with a stroke and is already on dual antiplatelet therapy, we tend to give 0.2 mg. That is not a recommendation based on what is available in textbook. It is a serendipitous discovery based on enchanted trial data, where enchanted trial data actually looked at altiplase treatment in patients who are on antiplatelet therapy. These data, it was showing that, see, for example, in altiplase, we have two doses like tenecteplase. There is 1.6 mg milligram kg bottle, which is approved dose in Japan, and there is a 0.2 per kg bottle, which is approved everywhere else. Now, zero point 0.9 is the correct dose which we are using, but Japan uses 0.6. But in the enchanted data, what they try to prove us is the low dose useful because we are Asian patients, are they useful? The answer was no, because many of the patients who belong to enchanted data were actually Asians, and 0.9 milligram was the correct dose. But in one circumstance, 0.6 appeared better. That was on patients who were on dual antiplatelet therapy. So in that case, the hemorrhagic complications were less. Using that in our patients, if they are already on dual antiplatelet therapy, which happens with a small by the cardiologist, we tend per kg body weight at that time. Otherwise, all our patients are 0.25. And today the recommendation is only 0.25 all over, I think. Gennova actually,
Recommendation of
our
India,
editor actually,
DC,
uh,
India,
follow
DC, Control General of India,
DCG. I think they have already submitted the
DCGI.
data by Amit. Amit, you are online, so you could tell us about our submission to the DCG about 0.25.
As on date,
Hello,
the DCGA approves 0.20 or 0.25.
So they have approved
Amit, you can
0.2,
come and
sir.
answer.
DCGI has approved 0.2 based on the data which we had submitted. But just to add a couple of points,
I think you have
globally,
submitted the next one also 0.25 also. Am I correct, Amit? Have you
no,
submitted the
sir,
data to them?
no,
No.
sir, no. We did the registry on 0.2 and our earlier studies were at 0.2. So the data from Indian patients is on 0.2, which we have submitted. There is global data, but that's at 0.25, but they did not have any patients from India. It was done in Canada, the ACT trial. And then there is data from the Australian population. What they did, Mark Parson, Bruce, Professor Campbell, and others.
Amit, what is the recommendation by the ISA? 0.2 or 0.25?
ISA, sir, I don't know, but I can say what the health ministry, they are saying 0.2. In their, the Ministry of Health, which is published by DGHS, they are saying injection tenecteplase 20 mg, and they have mentioned 0.2, and it can go up to 0.25. But from the DCGI, from the authority, it is 0.2 based on the data which we have submitted.
Thank you. Thanks for the clarification.
Maximum dose allowed 20 milligram. Is that right?
20 milligram. And
Yeah.
we were just to add there, we were in Hyderabad. There was one event. Dr. Vijaya Madam was, ISA was organizing. And then I met Dr. Jaiswal is there. He's a neurologist there, has been doing thrombolysis for the last 15 years. He was saying, he uses 0.2. So every hospital has, and he was saying, I only use 0.25 if the patient is fine. And I mean, there are no comorbidities or any other limitations, and then I go for 0.25. This is he's at Care Hospital currently, but he was at this various hospitals there, Dr. Jaiswal. So and just to add, most of the time it is always estimated weight. So and this is his experience. So he was saying so. And I
Balu,
would
what you are using, Balu?
Doctor, he was saying, sir, he is following 0.2 mg per kg. He said, I use 0.25 only if the patient is not on anticoagulants or not on any other risk factor. For most cases, I go with 0.2. And he is having excellent results. And actually in LVOs also, we were having some discussion. And he was saying, even in LVOs, because there's a risk of bleeding and so I know.
Amit, let me cut in and ask you. Tempo 2 data was 0.25 or 0.2? Bruce Campbell data.
But Bruce Campbell, sir, they have 0.25 because they were using 0.2.
That was also, when you're talking about the LVO, we take the best data from that. Bruce Campbell data was 0.25. 10% opening of the LVO.
Yes.
So maybe it's a good idea to go for into. That's my personal. Balu, what you are using, Balu? 0.2 or 0.25?
The thing is that after going through the literature and we discussed a lot of in the group also, when it's a large vessel activation, if I clinically suspect, I go for 0.25.
Okay.
And there are some issues, and then we feel that attendance is repeatedly, the bleeding risk are there, as you rightly said, that dual antiplatelet, elderly, and I go for 0.2. I individualized 0.2 or 0.25, and rightly said that all the weight that measured in most of the hospitals, your hospital may be having a proper weighing machine with the structure or the So that weighing is a problem. But so I train my ER physicians. We look at the patient and then tell the weight. So over the last 100 consecutive patients, they have to tell what is their approximate weight, and then they have to measure. So that is also a problem. We say it's 65 and then it comes to 75. So that is also a problem. So in that situation, large vessel occlusion 0.25, and clinically, I don't go for MRA for all the patients before doing a thrombolysis, you know that. So with CT, clinically, I suspect a large vessel, I go for 0.25, otherwise 0.20. And the doctors relative, they are repeatedly asking DCGA, those things, insurance, the PACA, DCGA, 0.20.
I think we have come to the fag end of the meeting. I think we are way past the time we should have finished, Baru. Maybe we can close. Again, I thank the MPure people for having provided this platform for this excellent discussion. Thank you, my wonderful moderators, Dr. Balu and Dr. Kavita Madam. And speakers, you are really wonderful, really. It was terrific listening to you. Thank you so much once again. Yet again, we'll meet in a next program. MQ people, if you have anything to talk, Dr. Pratiksha Madam, anything
Yes.
you want to share
No.
before we close?
No, sir. It was a very interesting cases that has been brought about and interesting discussion. So thank you to the speaker especially to bring out such interesting cases, and thanks to the moderators, both sir and ma'am, to bring about such discussion. And thanks to you, sir,
Thank
to
you, ma'am.
moderate the
Thank you.
session entirely. So thank
Dr.
you,
Thank you.
SMS is always it is a great learning for us. We always keep learning from you. It's I know sir from last 10 years, but
Thank you. Thank you, madam. Thank you very much. Thank you, madam.
thank you, sir.
Thank you, Balu. Thank you, madam. Bye.
Thank you,
Thank you,
SMS,
sir.
for your moderation.
Thank you, Balu.
I want to know, is it only 11 participants or more than that?
No, sir. This is
for us,
there
sir.
is more than it. Actually, there is an online separate link. I think there may
Oh.
be more than 100 participants.
Oh,
or so.
wow, very nice.
Last time SMS sir was when was Ganesh, we were 100 participants. I don't know this time. The cases are good. It could be even beyond that.
We have 119 participants, sir.
Yeah,
Oh, wow.
very nice.
How come we are not able to see that?
Yeah, that is different. The different
So
format.
they, ma'am, they joined via a different link. There is a separate
We can
delegate
have a
link.
good sleep seeing 100 people listen to all. Thank you. Good night.
Thank you.
Thank you,
Good
Balu.
night,
Bye.
everyone.
Thank you. Good night. Thanks for the opportunity.